Thank you, Vaishnav. Once again, good afternoon, one and all. Today we'll be having a sixth session of palliative care, physiotherapy in palliative care. And today we'll be discussing on the topic of pain. And today we have got the faculty of Dr. V. Ramamoorthy sir. I'm glad to introduce Dr. Ramamoorthy sir. Ramamoorthy sir currently working as professor and HOD of PMR, PhD Institute of Medical Science and Research Center, Coimbatore. After completing his MBBS in 1989, he has also pursued a diploma in PMR in 1997 and DNB in PMR 2001 and MD in PMR 2011. And his expertise in the fields like stroke rehab, diabetic neuropathy, pain management, cardiac rehab, and vestibular rehabilitation. And he also completed 14 publications in national and international journals. And he is having more than 20 years of experience in teaching and clinical services. And he also has very good experience in palliative care and rehab. We are happy to have you here, sir, and we are eagerly waiting to hear from you. And I welcome you for today's session, sir. Over to you, sir.
Thanks for the introduction. Right. Good afternoon to every one of you. Am I audible?
Yes, sir. You are.
Yes, sir.
Right. Thanks.
Yes, sir.
Right. Thanks. For the next 45 minutes, I will be discussing with you the topic Essentials of Palliative Care for Physiotherapists. I am Dr. Ramamoorthy, heading the Department of Physical Medicine Rehabilitation at PEG Institute of Medical Sciences and Research, Coimbatore. Next slide, please. Next slide. This is the profile of my institution. I welcome every one of you for this presentation. Next. Okay. The learning objectives of this session are: the participants will be learning about pain, what is total pain, pain mechanism, and pain classification. They will learn about skeletal metastasis, and they will learn about the techniques of pain management. Next. According to the International Association for the Study of Pain, pain is defined as it is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So in the statement, there are two items. Number one, pain is an unpleasant experience. Number two, it is associated with a tissue damage. Next. Dr. James Henry Cyriax, the father of orthopedic medicine, says all pain arises from a source. In case of periarthritis shoulder, the anatomical structure involved is capsule of the shoulder joint. In case of plantar fasciitis, the structure involved is plantar fascia. In case of osteoarthritis knee, the structure involved is articular cartilage. Like that, every pain arises from a source. Next. We'll see what is total pain. Next. A 60-year-old retired mill worker present to Physical Medicine Rehabilitation Department OPD in a stretcher with a history of severe back pain and paralysis of both lower limbs for the 2 weeks. He was referred from the neurosurgery department for rehabilitation. He was diagnosed to have metastasis in D7 vertebra and collapse of D7 vertebra. Ultrasound abdomen done showed cancer prostate. It was confirmed by serum PSA, serum prostate specific antigen. Next. So he had severe back pain. The pain scale was 8 out of 10. He was anxious and depressed due to his back pain and inability to walk. Next. He's a retired mill worker. So the source of income is cut and he has become dependent to his unemployed son. He is 60 years old. He has a wife and a son. His wife is suffering from Alzheimer's disease. His son is not having a permanent job. He always thinks, why did it happen to him? What will happen to his family if he dies? This is a punishment from God for the deeds done in his younger years. Next. So in this patient, the physical problems are, number one, paralysis of both lower limbs and back pain. Next. He has a pain in the back, collapse of the D7 vertebra and paralysis of both lower limbs. Next. What are the other problems he has in addition to physical pain? Next. He has psychological problems. He is depression and anxiety. Depression about not able to walk, anxiety about his future. Next. Social and financial problems. He is a retired one, no income. Now he is dependent on his son. Next. Spiritual problems. Why it happened to me? Is it a punishment from God? Is there really any God? Next. So these are the 4 dimensions of pain. So pain has physical dimension, social dimension, spiritual dimension, and psychological dimension. In this patient, physical dimension, pain and not able to walk. Social dimension, he's become lost his job and dependent on his son. Psychological problem, anxiety and depression. Spiritual problem, he suspects is there any God. Next. So the total pain encompasses physical suffering, psychological suffering, social and financial suffering, and spiritual suffering. Next. 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 In the previous one. Previous one. Right. So the physical problems are the tip of the iceberg. Under the iceberg, you see a huge building of ice. That is the emotional problem, social and financial problem, and spiritual problem. Next. So which component is usually addressed in the hospital? So in the hospital, we usually address only the physical problems. Next. So mechanism of pain. Next. What are the primary sensations? Next. The primary sensations are pain, touch, pressure, vibration, heat, and cold. Next. The pain receptors are free nerve endings. They are simple receptors found throughout the dermis. There are around 3 million pain receptors throughout the body. They are found in the skin, not only in the skin, muscles, bones, blood vessels, and some organs. Next. So this slide shows the receptors in the skin. They are pain receptors on the right side corner. You have free nerve endings. They are the pain receptors. In the middle, you have mucinous corpuscles and Merkel's disc for touch. In the left side, you have pressure for pressure, Pacinian corpuscles for thermal, Ruffini end organs, and cross and pulse. For today's lecture, we will remember the free nerve endings, which are the receptors for the pain. Next. So, as a physiotherapist, you must remember this. This is a very important slide. The nerve fibers are classified into 3, A, B, C, on 2 parameters. Number 1, whether the nerve fibers are myelinated or not, and depending upon the size of the nerve fibers. So nerve fibers are classified into A, B, C based on whether they are myelinated or unmyelinated. Then they are classified on the size of the nerve fibers. A nerve fibers are myelinated large size fibers. B nerve fibers are myelinated medium size fibers. C fibers are small unmyelinated. The A fibers, we have A alpha, A beta, A gamma, A delta. You have to remember A delta nerve fibers which carry the pain. Also C, the small unmyelinated C fibers also carry the pain. So you have to remember the pain impulses are carried by A, delta and C nerve fibers. Next. So the answer for this question, which nerve fibers carry pain sensation? A beta, A delta and C fibers, A delta, A beta and C fibers, none of the above. The answer is B. Nerve fibers carrying the pain sensation are A delta and C fibers. Next. Pain pathway. Next. So from the site of pain, the pain impulses are carried by the peripheral nerves to the dorsal ramus of the spinal nerve. There's a relay in the dorsal root ganglion. Crossing the dorsal root ganglion, they come to the spinal cord. Then they cross the opposite side. In the white column of the spinal cord, they ascend up as the spinothalamic tract. Next. So the nerve fibers, after crossing the spinal cord, it's the spinothalamic tract. The spinothalamic tract ascend up in the brainstem, namely medulla oblongata, pons, midbrain, and there's a second relay occurs in the thalamus. From thalamus, the sensor fibers reach the sensory cortex. So this is the pain pathway called spinothalamic tract. Next. Classification of pain. Next. So pain is classified based on duration, cause, and intensity. Next. Based on the duration, previous one, pain is classified as acute pain or chronic pain. Acute pain and chronic pain. Next. Acute pain usually comes suddenly. It is sharp in quality. It does not last longer. It goes away when the stimulus is gone. Next. Chronic pain, when a pain lasts for more than 6 months, it is called chronic pain. It is dull in nature. It affects the people to the point they cannot work, eat properly. Example, osteoarthritis knee. So you must remember, when somebody says chronic pain, the duration is more than 6 months. Next. And based on the cause, the pain is classified as nociceptive pain, neuropathic pain, mixed pain. Next. Nociceptive pain. Noci in Latin means injury or hurt. So whenever the free nerve endings, just now we have seen the free nerve endings are the receptors for the pain. Whenever any injury damages the free nerve endings, the pain is called nociceptive pain. Nociceptive pain is a type of pain caused by stimulation of the free nerve endings. Next. The nociceptive pain again divided into 3 types: somatic pain, visceral pain, radicular pain. Next. Somatic pain occurs or arises from a part of the body like muscles, bone, skin. It is a localized pain. It's a deep, dull pain. It getting worse with positional changes. There will be local guarding or rigidity. Next. So this person has a pain over the left side trapezius. It's a somatic pain. Next. Visceral pain. Visceral pain arises from the visceral organs, namely heart, lungs, stomach, intestine, liver, spleen, bladder, like that. So pain arises from the viscera. It is called visceral pain. The characteristic features of visceral pain are the pain will be a referred one. The pain source may be somewhere. The patient may feel the pain somewhere. So pain is of referred type. Intermittent colicky pain accompanied by nausea and vomiting. Next. So in this picture you can see, suppose this one, heart. Heart is here. The patient feels a pain. The pain radiates along the left upper limb, or it may the pain may be radiating to the back, upper back, or the neck region. It's called visceral pain radiating to the some other places. Next. Radicular pain. Radicular pain occurs when the nerve roots are irritated. So the pain radiates from the back to the arm or legs will be accompanied by numbness, tingling, and muscle weakness. Next one. So in this picture, you can see a disc has slipped and it is hitting on the spinal nerve root. Okay. So this is called radicular pain. Whenever the nerve roots are affected, the pain is called radicular pain. The patient will feel the pain wherever the nerve travels. Okay. Actually, the injury is here, but the patient feels here on the over the calf. It's called radicular pain. Next. Then neuropathic pain. Next. Next. Right. The previous one. Neuropathic pain, when the peripheral nerves are affected, the patient will have neuropathic pain. It may be affected by diabetes, alcohol, or nerve infiltration by tumors, or radiation therapy, chemotherapy drugs. The characteristic feature is the pain will be following a dermatomal pattern. I'm sure as a physiotherapist, you are all aware of the dermatomes from C2 to S5. So the pain will follow a dermatomal pattern, and the nature of the pain will be, next one, it may be burning or numbness or lancinating or like an electric shock. Next. So the types of neuropathic pain, the sensation may be increased or decreased. That is called, decreased sensation is called numbness. Increased sensation may be allodynia and hyperalgesia. Next slide. What is allodynia? I'm sure you are familiar with this term, allodynia. Pain due to a stimulus that does not normally provoke a pain. How many of us feel pain when we comb the hair? We don't. How many of us feel pain when we wear the shirt? We don't. Activities like this may produce pain in some people. This is called allodynia. A normal stimulus may produce pain. That's called allodynia. The basic defect is with the free nerve endings. The free nerve endings are malfunctioning. That is called allodynia. Pain due to a stimulus that does not normally provoke pain. This may include cold temperature, brushing hair, or wearing a cotton shirt. Allodynia occurs due to increased responsiveness or malfunctioning of the free nerve endings. Next. Hyperalgesia. Here, the stimuli is very powerful, painful stimuli, so the patient feels more pain. So the difference between allodynia and hyperalgesia, allodynia, the stimulus is mild one. Because of the malfunctioning of the free nerve endings, the patient feels more pain. But in hyperalgesia, the stimuli is very powerful, so the patient feels more pain. Next. Sometimes there may be a combination of nociceptive pain, neuropathic pain. In nociceptive, noci means already I told trauma to the nerve endings. So it is in the periphery. So the pain may be in the nociceptive, the pain receptor level, or it may be in the peripheral nerve level. So some patients may have both. That is a neuropathic pain and nociceptive pain. Next. Based on the intensity, pain is classified as, next. Based on the intensity, pain is classified as mild, moderate, and severe. Next. So mild pain, you will see in the subsequent slide, the numerical pain rating scale. When the scale is the pain is between 1 and 4, it is called mild pain. Pain is between the range 5 and 6, it is called moderate pain. Between 7 and 10, it is called severe pain. Next. So in the numerical rating pain, the patient will score wherever he feels the pain. Suppose the patient ticks 3, it's a mild pain. 8 means severe pain. It is based on the patient, it's a subjective phenomenon. Next. So this is a sum up classification of pain based on the duration, acute pain, chronic pain. You must remember, when somebody says chronic pain, the pain lasts for more than 6 months. Then cause, nociceptive pain, neuropathic pain, mixed pain. Nociceptive means trauma to the free nerve endings. The types of nociceptive pains are somatic pain, a part of the muscle, part of the bone, somatic pain, visceral organs, radicular pain when the nerve roots are irritated. Neuropathic pain, allodynia, small stimulus may produce severe pain. Hyperalgesia, severe stimulus, more pain. numbness, no pain at all. Then there may be mixed. The patient may have nociceptive as well neuropathic pain. Based on the intensity, the pain may be classified as mild, moderate, and severe. Next. Based on the course, patient may say here continuous pain, intermittent pain, eruptive pain, and incident pain. Next. Continuous pain, all the 24 hours of a day. This will happen towards the terminal stage of the malignancy with the secondaries. Next. Intermittent pain, pain comes and goes, episodic pain. Next. Eruptive pain, again, it occurs in the end stage of the cancer. Next. Incident pain, it's a temporary pain, it's transient pain, it comes and goes. It occurs on movement, rapid onset, severe intensity. The patient requires rescue dose of drug. Next. Breakthrough the pain, again it occurs in cancer patients. The pain may be well controlled with drugs. Suddenly pain may appear. This is called breakthrough pain. Breakthrough pain is sudden, brief pain that occurs during a period when chronic pain is generally well controlled by opioids. Breakthrough pain may happen when the patient is at rest or related to activity. Next slide. So in this slide, the patient has breakthrough pain. It is well controlled by pain medication. Even with this, suddenly the pain may appear. This is called breakthrough pain. Next. Inflammatory pain in any abnormal inflammation like rheumatoid arthritis, psoriatic arthritis, ankylosing spondylosis, there may be pain. Next. Functional pain, there is no cause or origin, but the patient may complain of pain. Next. So this is the consolidation of the various classification based on the duration, acute and chronic. Based on the cause, nociceptive, we have somatic, visceral, radicular, neuropathic, and mixed. Course, continuous, intermittent, incident, eruptive. Intensity, mild, moderate, intense. Next. Assessment of pain. Next. What are the specific questions to be related? Asked. Next. Previous one. Okay. There's a mnemonic LD, PQ, RST. It's a ECG wave. You can easy to remember LD, PQ, RST. Location, duration, provocative factors, quality, radiation of pain, severity, temporal factors with reference to time. Okay. Next slide. This is another way of asking. The mnemonic is Socrates. Site of pain, onset of pain, characteristics of pain, radiation of pain, associated symptoms, timing of pain, exacerbating and alleviating factors, severity. Next. How to measure severity of pain? So we have lots of pain scales. Next. Next. What is the name of the scale? Can anyone tell me the name of the scale?
Visual analog scale.
VAS scale.
Sorry?
VAS scale. Visual analog scale. VAS scale.
No, it's wrong. I will tell you. Any other answer? It is not visual analog scale.
Subjective pain scale.
There are many adjectives. No, mild, moderate, severe, very severe. Was many adjectives. This is called
Subjective.
Next slide. Verbal pain intensity scale.
Okay.
This is called verbal pain intensity scale. Right. Next. Right. Next one. What is the name of the scale?
NRS, numerical rating scale.
Sorry?
NRS.
No,
Numerical.
it's wrong.
Check one.
Any other? Pre and shoe. Can you tell me what's this?
It's the pain thermometer scale.
Okay, this is the analog scale. Okay, analog means there's a pointer. So in the watch we have pointers, small size pointer, long size pointer. Like this is a pointer that will move across from 0 to 100. Okay, there's a pointer here. Actually, we will show the reverse side of the scale to the patient. On the one side, you see 0 to 100, 0, 10, 20, 30, 40, 50, 60, 70, 80, 90, 100. We don't show this side to the patient. We'll show the other side of the patient, other side of the scale to the patient. On the other side, there are only two lines, 0 and 100. Patient has to mark somewhere, depending upon the pain. Then we reverse the scale and bring the pointer to the point. From 0, we will measure. Okay, this is called visual analog scale. Analog means there is a moving pointer. Next one. So this is the visual analog scale. Next. So the visual analog scale is showing information using hands that move around the dial. Once the patient has marked the spot to signify his or her perception of pain, it is time for the medical practitioner to score and interrupt the intensity of pain. 0 to 4 millimeter no pain, 5 to 44 millimeter mild pain, 45 to 74 moderate pain, 75 to 100 severe pain. Next. What's the name of this scale? What's the name of the scale? NRS scale from Pre and Shoe. Yeah, that's a perfect answer. This is a numerical pain rating scale. There are numbers, isn't it? There are some numbers are there, so it is called numerical pain rating scale. Next slide. So it's called numerical pain rating scale. The patient ticks number 2, it's a mild pain. 7, severe pain. Next. We mainly use this for children. Okay. What's the name of this scale?
Baum-Baker's Faces scale.
Excellent.
Excellent.
Excellent. That's a perfect answer. Next slide. Wong-Baker Faces scale, mainly used for children. Next. So body chart. Okay, you lost a patient which area he or she has pain. Okay. Can you quickly go through all the 5 pain scales? Starting from the verbal pain intensity scale. Can you go back? You will just see the slides. Previous one. Yeah, stop. This is the verbal pain intensity scale. There are adjectives: no, mild, moderate, severe, very severe. This is called verbal pain intensity scale. Next. Next. This is the analog scale. I told you previous. Analog means there's a moving pointer. Okay, this is the visual analog scale. This pointer will be moving from 0 to 100. Next. This is the numerical pain rating scale. There are numbers called numerical pain rating scale. Next. Wong-Baker Faces scale. Then you have body chart. Right. Next slide. Gate control theory of pain. It's a quite interesting one. Before that, what are the nerve fibers carrying the pain sensation? You can use the chat box. What are the nerve fibers carrying the pain sensation?
C delta and A fibers.
A delta and C from Monica Saxena. A delta and C from Tarun. Right, good. Right, very good. Now with this background, we will see what is gate control theory. Next. This gate control theory was proposed in 1965 by Melsack and Wall. Next. So there is a pain gate located in the spinal cord. You are seeing the cross section of the spinal cord. This is anterior or ventral. This is dorsal or posterior. So this is the dorsal column of the spinal cord. This is the ventral column of the spinal cord. In the dorsal column of the spinal cord, there are 10 laminae, and the second lamina is called the substantia gelatinosa of Rolanda. Okay, this is the second lamina. This is the pain gate. So when somebody asks you where is the pain gate, I have set the MCQ question, where is the pain gate? Pain gate is located in the dorsal horn of the spinal cord. So second lamina, substantia gelatinosa Rolanda. Next. So this patient, he has a pain in the trapezius, left trapezius. So from here, the pain impulses are taken to the sensory cortex by which nerve fibers?
A delta.
Correct, A delta, mainly A delta. Okay. At the site of pain, we are giving some stimulus through next. Through this equipment TENS, we are giving some stimulus that will make a massage and pressurize that area. So the pressure sensation will be carried by previous slide. What is the nerve fiber carrying the pressure sensation?
A beta. A beta.
A beta.
Very good. Pressure sensation is carried by A beta, pain is carried by A delta. Among the two, which is the largest size fiber?
A beta is the largest size. A beta.
Correct. Among the two, when you compare A beta and A delta, A beta is the largest nerve fiber compared to A delta. What happens? Next slide. So at the over the left trapezius, we apply TENS and give stimulus that will give a massage. The pressure sensation are carried by A beta fibers to the spinal cord, dorsal column. Next. So presume this is the left trapezius. Patient has pain. Pain is carried by A delta and C to the spinal cord. From here, we apply TENS and give stimulus. There will be pressure or massaging effect. This will be carried by which nerve fiber? Pressure?
A beta.
A beta.
A beta. A beta fibers carry the pressure sensation from the same site, left trapezius to the spinal cord. Now, in the dorsal column of the spinal cord, that is the pain gate. What's the name of the pain gate? Where is it located? Pain gate is
dorsal horn of spinal cord.
Substantia gelatinosa.
Substantia
gelatinosa.
Substantia gelatinosa of Rolando. Now, at the level of the substantia gelatinosa Rolanda, two impulses. One, pain impulses carried by A delta, pressure sensation carried by A beta. Now, the pain gate decides which is important stimulus or important sensation. The pain gate decides the impulses carried by the large size fibers are important. So it stops pain impulses at the pain gate. It opens the pain gate for the pressure sensation. Only the pressure sensation will go to the thalamus and sensory cortex. Pain impulses are stopped at the pain gate. So this is the pain gate mechanism. Next slide. So the size A beta 5 to 12 nanometer, A delta 2 to 5 nanometer. So the A beta is largest size nerve fiber. So large size nerve fibers have a high conduction velocity. Next slide. I will give you an example. Okay. This is one, we will say this is a Trivandrum railway station. There are two trains. And this is a super fast express going to Chennai. This is another train, but this is a goods train. We presume this is a goods train. This is also going to Chennai. Okay. Now, which train will be allowed to go first? The station master will allow which train to go first. There are two trains. This train also going to Chennai. This is also going to Chennai. This is a passenger train. This is a goods train. If you are a station master, which train you will allow to go first?
The passenger train.
Why?
Because it's having the people to travel.
People have to reach their destination at the earliest. They want to finish the work in the daytime. They want to come back to Trivandrum on the same day. Okay. So the priority is allowing the passenger train to go. The same thing happened at the pain gate. The pain gate allows impulses carried by the large size nerve fibers. The large size nerve fibers will go fast because of the large size, they have the high conduction velocity. Okay. So this happens in the pain gate. It's called pain gate mechanism. Next. Okay, spinal metastasis. Next. So almost all the cancers may spread to the bones. The most commonly breast and prostate cancers. They may spread to any skeleton, mostly on the skull, vertebrae, ribs, pelvis, and femur. Next. So these are the sites where the secondaries will settle: skull, humerus, ribs, spine, pelvis, and femur. Next. So in this picture, the third metacarpal, there are secondaries. Almost the bone is damaged. Next. The secondaries in the head and upper one third of the humerus. There's a pathological fracture in the upper one third of the humerus. Next. Secondaries in the pelvis. Next. Secondaries in the brain. Next. Secondaries in the spinal cord, in the vertebral column. There is a collapse of the vertebra. Next. So the complications, whenever the bone secondaries are there, the patient may have bone pain, hypercalcemia. Calcium will be released from the destroyed bone. There may be pathological fracture, and there may be compression of the spinal cord. Next. There are two types of bone cells, namely osteoblast and osteoclast. The bone tumors, they stimulate both osteoblast and osteoclast. Osteoclast, when there is a stimulation of the osteoblast, there may be production of the more bone cells. When there is a stimulation of the osteoclast, that will dissolve the bone, leaving the weakened bones. So there may be osteolytic lesions. It may break down. So from the bone, the excess calcium will come to the bloodstream. Next. So clinical presentation, whenever the patient has bone metastasis, there may be local pain. There may be compression of the adjacent structures like spinal cord. Next. There may be pathological fracture without any injury. Trivial injury may cause a fracture, pathological fracture. Because of the osteolytic lesion, calcium may be released from the bone. There may be hypercalcemia. The symptoms of hypercalcemia may be constipation, nausea, loss of appetite, frequent urination, thirst, and dehydration. Next. From the primary tumor, the tumor may spread to the bone either through blood or lymphatics. Next. Imaging. Next. So to see the secondaries in the X-rays, at least 30 to 50% of the bone mineral loss must be there. Then only you can see the secondaries in the X-rays. But it can be picked up on an earlier stage through bone scan. Next slide. So the bone scan, where there's a high hotspot, in the earliest stages itself, the secondaries can be identified. Next. So what's the treatment? You have to treat the primary, either remove the tumor, then radiotherapy, surgery, then pain management. Next. Prognosis, when the patient develops skeletal metastasis, usually the prognosis is guarded, very bad prognosis. Next. Physical therapy management. Next. So physical therapy intervention focuses on four things. The patient with spinal metastasis. Number one, to maintain independence as possible, as much as possible, to be optimizing the functional capacity of the patients, preventing the pathological fracture, and keeping the patient from becoming bedbound. Next. A study was conducted where 54 patients were involved. They all have bone metastases. Okay. They all undergo rehabilitation. Among the 54 patients, 16 fractures occurred in 12 patients. After 16 fractures, only one fracture occurred during the process of rehabilitation. All the 15 fractures happened on its own when the patients are bound to the bed. So the study showed the rehabilitation is not contraindicated in patients with bone secondaries. Next. So when you come across patients with bone metastasis, you must be very careful. Manual muscle testing, either passive or active strangulation, to be avoided. Resistive exercises to be avoided. Only active movement, whatever patient does on his own, must be assessed. So treatment sessions should focus on training the patient to use the residual functions left over. Next. Non-pharmacological management of pain. Next. So we have physical agents: heat, cold, water, sound, electricity, electromagnetic waves, IRR, UV, short wave, medium wave. These modalities are adjunctive treatment rather than primary curative intervention. Next. Physical agents relieve pain by two means: directly, indirectly. Directly, altering the nerve conduction by moderating the release of inflammatory mediators, modulating the pain at the spinal cord level, increasing the endorphin level. Next. Indirectly, the physical agents reduce pain by decreasing the sensitivity of the muscle spindle system, thereby reducing the muscle spasm. They modify the vascular tone and the rate of blood flow, thereby reducing the edema and ischemia. Next. So first one, cryotherapy. Application of cold in the form of ice pack, ice massage, cold whirlpool or cryo cup. The temperature must be 10 to 15 degrees, time 5 to 15 minutes. The cryotherapy, it controls acute pain by reducing the metabolic rate, by controlling the edema and ischemia. Next. So it's an ice pack, ice massage, cryo cuff and cold immersion. Next. Contraindication for cryotherapy: whenever the patient has peripheral vascular disease or Raynaud's phenomenon, hypersensitivity to cold, skin anesthesia, open wounds infection are contraindicated. Next. Will cryotherapy beneficial in this patient who has D7 vertebral fracture and pain in the upper part of the back? Will cryotherapy beneficial for this patient? Patient who has upper back pain, fracture of the D7 vertebra, will it be beneficial? You have to say yes or no.
Basically, spasm of the muscles.
Sorry.
Yes,
I
Yes.
couldn't hear, sir. Sorry.
yes, sir.
Okay, right. Next slide. Wax therapy. So paraffin is heated in a thermostat controlled container. Okay, the temperature set is 40 to 44 degree. The technique of application, either directly pouring method or brushing method, direct immersion or dipping method, doubling or bandaging method. Where do you apply liquid paraffin to wax?
Peripheries.
Sorry?
Peripheries. The upper limb and lower limb.
No. My question is, in the wax part, you have to apply liquid paraffin. Any idea?
When we want that part to be in
Lubrication
the,
of joints.
for a period of time.
No, yes, understand the question. Actually, in the wax part machine, along with wax, you have to apply liquid paraffin. Why? Why liquid paraffin is added to the wax?
Or to decrease the specific heat of the
Okay, if you don't know the answer, I will tell the answer. Okay, the liquid has the wax has a high melting point. Okay, to reduce the melting point of the wax, we apply liquid paraffin so that the melting point comes to 50 to 57. Okay, the actual melting point of wax will burn the skin. To reduce the melting point of the wax, we always add liquid paraffin. Right. Next. So these are the various methods: brushing method, dip and trap method. Next. Next. So pain relief. So here to remember previous slide. Whenever you use the moist heat therapy or wax, you have to remember the latent heat effect. That means it is the ability of the wax to retain the heat energy and slowly release the heat energy. That is the difference between when you apply wax and hot water. Okay, this latent heat effect will not be there when you apply hot water. When you apply wax, the wax will retain the heat energy for some time and slowly releases heat energy over the period of time. This is called latent heat effect. This is the difference between applying wax and applying hot water. Next slide. Will the wax therapy beneficial for this patient who has no?
No.
Any other answer?
With the towel method, you still can try, but it looks no. It appears no.
Any other answer? Will
Can we know the condition actually is suffering, because I couldn't hear that part, doctor? Sorry. The diagnosis is?
this patient has a fracture of the vertebra D6, pain in the upper back.
No, we cannot apply wax.
Can you apply wax to the patient for pain relief?
No, we cannot apply.
Any other answer?
Heat increase the blood circulation. It may increase the metastasis.
Any other answer? Megha Deshpande, no. Any other answer? Yes or no?
Yes.
No. Can you justify no? Sumita Matai, can you why no? Smita Matai has typed no. Can you justify why no? Somebody answer. Please.
Sir, in the back, we can't apply wax
Okay. Why?
because it's not possible to apply at that area.
No, somebody can apply. A very interesting answer. Rajalakshmi says yes, we can.
Yes, we can apply with the towel method.
Say yes.
But in this condition, no.
You can say yes, you can say no. You have to justify.
You cannot.
Somebody said no with a valid answer. Can he, the boy, can repeat? Why no?
Was it right, doctor?
Sorry? Tarun.
Sir, it will increase the bone metastasis, no? That's why it's no.
No, Abhilash says the moist heat therapy may cause vasodilatation, that may cause spread of the tumor. It's an acceptable one.
Right, doctor. Agree.
But Rajalakshmi says it may relieve spasm, we can apply. Okay. But
For releasing vasospasm, we can use hydrocolloidal pack. That's better than wax.
okay, right. Next slide, please. Ultrasound. The sound waves are audible between 20 to 20,000 frequency. Less than 20 is infrasonic. More than 20 is ultrasonic. It's a deep heating modality. Next. So here, the domestic electrical current, which has 220 volt and 60 cycle, is converted into a high frequency electric current. This high frequency electric current will pass through the piezoelectrical crystal. That will produce the ultrasound wave. It's called piezoelectrical effect. Next. So ultrasound may control pain by stimulation of the cutaneous thermal receptors, increasing tissue extensibility, modulation of the pain. Next. So the parameters, 1 megahertz frequency, 1.5 to 2 watts per centimeter square, or 3 megahertz frequency, 0.5 watts per centimeter square. Technique of application, always we use a medium between the head of the ultrasound head and the body, in the form of a gel. Next. So various methods of application, direct method, immersion method, bladder method. Next. So the therapeutic effects of ultrasounds are thermal effect, non-thermal effects. Non-thermal effects, cavitation, formation of small tiny gas bubbles, acoustic streaming, that's a unidirectional fluid movement around the vibrating bubble. Then micro massage, a mechanical effect causes molecules to vibrate, thus enhancing tissue fluid interchange and affecting tissue mobility. Next. Will it be useful for this patient? Ultrasound therapy to this patient who has upper back pain. You can say yes or no with, you have to justify your answer. Why yes, why no?
No, sir. The same, because it will increase the bone metastasis.
How come?
Because of the vasodilatation, the circulation will be more. So there is a chance of getting bone metastasis more.
Okay. One second reason, usually we use ultrasound for focal lesions, like a small lesion like lateral epicondylitis, plantar fasciitis. Here the patient may have pain over the broader area, upper back, entire upper back. So the ultrasound may not be of that much useful. Next. An interferon therapy. Here we use two medium frequency current, A and B. A 4100, B 4000, and at the intercepting point we have the beat frequency of 100 hertz. Okay, next. So the clinical application for pain relief, muscle stimulation, that may increase local blood flow and reduction of the edema. Next. Relief of pain is achieved by stimulation of the reticular formation or by blocking the C fiber transmission. Next. Can you apply IFT over the painful area?
Muscle also will be getting stimulated, which is not required here. We don't want movement.
Sorry?
If we use IFT, it will also induce the muscle contraction in the deeper muscle. So it will cause the movement in the flexor side, and we don't want that movement.
Okay, any other answer? She says yes, yes, she says no, and she justifies. Any other different answer? Can you apply IFT over this painful area?
No, sir. No, it may have deeper effects compared to TENS. So we cannot give IFT to that in this condition.
What will happen? You apply IFT, what will happen?
It may again, it may increase the muscle contraction. That may increase the fluid flow. That is lymphatic or blood circulation may increase by IFT.
Somebody said yes. Can you type again? Dr. Shruti, increase in blood supply. Okay, next slide. TENS, that's a transcutaneous electrical stimulation. Next one. So we have conventional TENS, acupuncture TENS, burst TENS. Next. So high frequency TENS. So low frequency acupuncture TENS. Next. So burst TENS. Next. So the TENS provide analgesia when applied at a strong non-painful intensity. TENS may be useful for fibromyalgia and spinal cord injury. Next. Will it be beneficial for this patient applying TENS?
Yes, yes.
Why yes?
Because the same it will stop C fiber to send the sensation up at the gate.
Abhilash.
Yeah, we can use it at the spinal level. the action at spinal level, no? So we can use. There is no factors to improve the bone metastasis.
Any other answer? You can say yes or no. You have to justify.
So yes, we can give 10s.
Okay.
We can give 10 because it has only superficial effects.
Next slide.
It won't go deep.
It's called through heating. It will be increase in skin temperature 1 degree, 2 to 3 degree, or 3 to 4 degree. When the temperature increases to 1 degree, there will be reduced inflammation, increased metabolism. 2 to 3 degrees, decreased pain and muscle spasm. 3 to 4 degrees, increased tissue extendability. Next. Next slide. So this is the parameters. Frequency 27.12 megahertz, wavelength 11 meters. Next. Modes or methods of application, contention method or cable method. Next one. Can you apply short-wave diaphragm over this pain-free area?
Strictly contraindicated, sir.
Strictly contraindicated. Why?
Because it is for deep heating, and we can cause further damage to the bone. Especially, we can cause further sclerosis. Not sclerosis. The rim where we have the fracture site, the injury
Right.
will be further disintegrated. The SWD is not used even in the pulse mode because it looks acute condition. There is associated swelling around.
So that's
we
a
cannot use.
How are you still using short-wave therapy in your clinic or institutions? Short-wave diaphragm?
No, sir.
No. Right. Next slide. Laser. The acronym laser stands for light amplification and stimulated emission of radiation. We have helium neon laser and gallium arsenide laser. Next. So the methods are green method or scanning method. Next. Uses for pain control and tissue healing. Next. What about laser?
Yes, it can be used because it is more safe, it is not deeper, and scanning will cover wider area.
Any other answer? Yes, thorough. Complete.
But still, it is not the preferred choice.
If it is available in your center and you have a similar patient, will you apply?
Maybe not preferred, doctor.
Right. Any other answer? You can say yes or no, but you have to justify. Next question. Next slide. Traction. Traction is used in ancient times. So we have mechanical traction. Right. Next slide. So 60-second traction, 10 to 20 seconds rest, time 30 minutes. Lumbar traction, 1/4 of the body weight. So approximately cervical, 1/6 of the body weight. Next. Next. Can you apply? Can you apply traction for this patient?
No, doctor.
Why?
It will distract.
No, already he is paraplegic. This will worsen the symptoms. Okay. So it's an absolute contraindication for traction. Right. Next slide. Okay. Braces for bone metastasis pain. Next. Okay. This patient, the patient we discussed, who has a fracture of the D7 vertebra and compression of the spinal cord, requires hyperextension orthosis. All the braces act on 3-point pressure system. On the anterior side or ventral side, there are 2 pressure points, one over the sternum, another one over the pubical area. On the posterior or dorsal side, there is a pressure point at the lumbar level. It functions to give a hyperextension movement. This will open the collapsed vertebra. It applies 3-point pressure over the sternum and pubis and over the upper lumbar spine, used to permit upright position while preventing flexion after a compression fracture of the vertebral body. So this can be applied to our patient. Next. It's for protecting the skull from when the patient has a secondaries in the skull, that will be protected. Next. For protecting the upper part of the humerus. Next. Next, hip, pelvic splint. Next, for thigh brace with pelvic support. Next. So with this, I have completed my presentation. So the takeaway from this presentation are what is meant by total pain. Always in our practice, we treat the physical pain. We must take some time to discuss with the patient about the other dimensions of pain, namely psychological, social, and spiritual pain. The pain receptors, dash is a pain receptor. Dash is the pain receptor. Can you fill up the blank?
Prenerve ending.
Prenerve endings are the pain receptors. The nerve fibers carrying the pain impulses are
A delta and C.
A delta and C.
A delta and C. Pain pathway, what's the tract carrying the pain sensation from the spinal, from the periphery to the brain? Spinothalamic tract. Classification of pain based on the duration, based on the intensity. Then assessment of the pain, we have various pain scale. Then we have gait control pain. Can anyone tell me the mechanism of gait control theory? Where is the gate? Where is the gate located?
SG of Rolando.
Gelatinosa of Rolando in the dorsal column of the spine. How is the pain modulation? The pain modulation occurs in the pain gate. How does it happen? At the site of pain, we produces some other sensation, pressure sensation through muscle.
Pressure
Fibers.
Pressure by beta fibers.
A beta fibers, which are larger
They
than
are in
Size.
larger than A
large size,
delta and C fibers.
have a high conduction velocity. So the substance gelatinosa Rolando pain gate thinks the impulses carried by the large size fibers are important. They should be allowed first to reach the brain. So they stop the A delta nerve fibers, size fibers carrying the pain. So that's a gate control theory of pain. Then bone metastasis, you have to remember B and P. The primary from the prostate and primary from the breast. Usually they metastasis to the bone. They are usually skull, vertebra, spine, pelvis, and femur. Pain management by various modalities. So among the modalities, which one you have chosen without any contraindication?
TENS.
TENS.
Cryotherapy.
Next slide. So after this lecture, I'm sure you must be able to assess the assessment of pain through the various scale, management of pain using the various physical modalities, the knowledge of assisted devices for reducing the pain due to metastasis. Next. Right, this is my favorite slide. I hear and I forget. I see, I remember. When I do, I understand. Right, with this, I have completed my presentation. Now, someone is going to present. We will hear the presentation, then we can discuss. Any questions from my presentation? Thank you, Tarun. Now we can have a presentation by one of the participants.
Yes, sir. Yes, sir. Thank you, sir. Thank you for the wonderful session and very informative. And it was very informative. Thank you for the wonderful presentation, sir. And if you have any doubts or any comments on regarding sir's session, you can comment on our chat box. We can discuss it after the case presentation. And now it's time for the case presentation. And today, a case is presented by Mr. Murugavel. And I welcome him and over to Mr. Murugavel.
Hello, good evening, everyone. So my name is Murugavel Manivasagam. I'm working as a physiotherapist in Brunei. So today we're going to see about a case report on patient. Maybe next slide. So I'm going to talk about this lady who is 57-year-old, married with 2 daughters, and she's a Muslim lady. And her diagnosis is breast CA with metastasis to multiple level in spine and having a severe pathological fracture on right side neck of femur. And she has been consulted by oncologists as well as orthopedic surgeons. They decided she's not a suitable candidate for the surgery. Next slide. So she presented with certain complaints, a severe pain in her right hip and a low back region, and she's wheelchair bound for some time. She's working as a teacher in a government school, but she was on long sick leave. She has a lot of difficulty in doing her ADLs due to her pain as well as in a reduced mobility. Next slide. History of illness. In 2018, she had a breast surgery, left wide local excision, and also left V lower inner quadrant mammoplasty and axillary node clearance. And it's graded as grade 3 intraductal carcinoma A. And she completed her RT to breast and also had a chemo. In April 2021, she found to have a bone mets in multiple level of spine as well as pathological neck of femur fracture, right side, and not suitable for the surgical intervention. Initially, she able to take a few steps before diagnosing her fracture with assistance, then cannot able to tolerate pain, and she become wheelchair bound. So doctor informed the family about her prognosis, about her end stage of cancer, and she has been referred to palliative care team. Next slide. So on physiotherapy examination, her active range of motion in upper limb was very good. Also the muscle power is good. Active range of motion right hip is limited in flexion and also limited in abduction, all movements. It is very painful. And muscle power is, we cannot able to assess completely, but still she have muscle power around 3 out of 5. Also in abductors, 3 out of 5. Her gait is very limping gait. When we tried few steps, she can able to just weight bear a little bit in on toes, and with 2 assistants grabbing her axilla. And she had presence of pedal edema on both legs and foot. That is because of long time wheelchair bound. And her pain in numerical pain scale is around 7, which is moderate pain. And we use 2 scales, which is called brief pain inventory, but we didn't use the complete brief pain inventory, but we use this component called pain interference scale. So this is to assess how much the pain interfere in the daily activities, including a sleep, work, also the relationship with the people. So how the pain interfere with all our daily activities. But in normal brief pain inventory, it will be around measuring the quality and intensity of pain in 24 hours. That is a different scale. This is a pain interference scale. So it has 7 domains, and she scored 56 out of 70. That's a big high score on that. She have a pain interfering with her life a lot. So we also did IADL assessment using this CATS index, which is one of the valid measure they are utilizing in research for end-of-life patients with cancer. So she is scored 3 out of 6. Again, this IADL measure is assessing about her bathing, dressing, transferring skills, feeding, as well as continence, everything. So in this scale, she scored 3 out of 6, and she is moderately dependent. Next slide. So the treatment and significant investigations, evaluation by PT. So we assessed pain as well as her fatigue, strength, and rate of perceived exertion through simple bed exercises. That is very important for us to assess priorly, to set our treatment plan for us, to give her what type of exercises and how much exercise she can able to do. And false risk, obviously she is false risk patient and she's wheelchair bound. And we did assessment as well as we helped the carers for manual handling. Since she have a femur fracture, we ask how to hold the patient to transfer from wheelchair to commode as well as to the closets. So the OT is also involved. They basically do their home assessment, the plan for once the patient discharged, what she can do at home, whether the wheelchair is accessible to her home, as well as she's a teacher, but currently when she was on leave, And still our OTs will be doing a work-based assessment regarding whether she have accessibility to go to her class at least weekly once or not, and to assess her wheelchair mobility skills, to self-drive the wheelchair on herself, because she have a very good power in her both upper limbs. And she has been referred to radiotherapy for the pain management too. And she has been referred to psychologists to assess again more specifically mood, stress, and to understand her coping ability with the pain, as well as what is her preference and expectations she expects from all the multidisciplinary team. And palliative care physician is involved for pain management, especially with pain medication, to prescribe pain medications. And Ustaz is the religious preacher in Muslim Islam. They talk about more of spiritual counseling. Next slide. Psychosocial aspects. Patient is really very depressed with her pain and immobility affecting her ADLs. And she have two of her sister previously affected with a strong familial history of cancer, and they passed away. And she desperately also wanted to go back to work, at least as a part-time. So, but wheelchair accessibility is a problem in school. Her desire also to attend one of her daughter's graduation in presence. So she have two daughters, and she really wanted to attend the graduation of her daughter. And she's a Muslim and worried that she cannot able to do the prayer in a flow. Next slide. So she was under this medication called letrozole, which is hormonal. The tablet works under hormonal related breast cancer, changing her hormonal changes. And Zomata, which is also mostly they will prescribe this tablet for the patients with bone metastasis for reducing the spread, as well as in high calcium levels, those who are risk at bone fractures. So also she's on opioids from our palliative care consultants. Next slide. Next slide. Yeah. So our main concerns we categorize into physical, psychological, socioeconomic, and spiritual. So physical is pain in her lower back and hip region. She's a wheelchair bound and cannot able to walk independently with assistance. Pain interfere with all her ADL activities. Psychologically, she is very depressed, as we seen previous slide. So two sisters already passed away due to cancers. She is more dependent now on her husband and kids to be mobilized and not going out anywhere. She would love to go for shopping and, at least for school in a week, at least once, but she couldn't do that. So she desperately wanted to walk at least few steps so she can able to go to work. So socioeconomic, she don't have any issue with economically, because here the government provides them with a lot of benefits. So she get a salary even though she's not going to work, but she affected psychologically because she cannot meet her friends as well as relatives. And so that is a big concern for her. And spiritually, she could not do her prayers on floor. And also she was questioning about why her family alone get a lot of cancer patients, and her two of her sisters passed away. So she have a lot of inner thoughts about why it's happening to only her. Yeah, next slide. So physiotherapy intervention, I'm focusing only on what physiotherapy side we did. So pain education, explaining about her pain, like what our doctor presented right now. So what really happens, why she have pain. And as we know, we have seen in our presentation previously by the doctor. So there are pain which is very nociceptive, where you have evidence of tissue damage, and there is a bone fracture, and it don't heal faster for this patient, and there is no surgical options. So we need to explain her about this, and we need to make her understand how she can modify her daily activities and limited to her settings, right? And also teaching her self-management strategies, how to cope up, how to pace the activities in a day, how she can break up her activities in a day in kitchen or at work, or if she plan to go to school, how much time she need to spend there, right? Apart from pain education, we also given pain management using TENS, both for the lower back as well as in right outer thigh area. And we advised her to use warm water bag application at home. That is one thing which she can do at any time. Since she is sitting for a long time, she feels some tightness in the low back, as well as she will have complaints of thigh pain. So we advised her she can use water bag at home. And exercises, gradually it took few months for us to train from sitting to stand. So initially we did a lot of sitting exercises. Slowly we tried to make her utilize wall ladder, holding a wall ladder, and try to give partial weight in the front of the toes and try to sit to stand with the Zimmer frame as well as in the wall ladder. And we given active range of motion exercises as tolerable for the knee and ankle. Still the knee is very good and ankle is good. So given good exercises for right knee and ankle. Strengthening exercise for both upper limb in sitting. So where we use TheraBands, elastic bands, and mild dumbbells to strengthen our upper limbs, which is very essential for her because she need to take all her weight. If she is doing a partial weight bear gait training, so she need to have a good endurance and strength in her upper limb. So we added more of strength training to her upper limb. Gradually, we progress walking with Zimmer frame with supervision for at least 10 steps, but we clearly indicated this has happened with consultation with the doctor since patient expects she need to walk, and we clearly indicated she should not walk for a long time at home. This is just to make sure she can able to take few steps so where she can be more independent in her activities. But we discouraged her doing that because it's active fracture, so we don't want her to overdo it. So, but we make sure that she can take only few steps with Zimmer frame. So we regained her confidence in that level. So setting a realistic goals, and as we know, patients might have really a lot of unexpected, and we can say like more expectations with the present condition, when it will recover, when can she drive, or when she go back completely to work. So we just say we need to sit and discuss with them and set a realistic goals, how much they can do all these things and what we can expect from the therapy. So we encourage to socialize actually, taking with the wheelchair, we encourage her to go out for shopping because she's stressed, she couldn't able to meet the relatives and not attending school. And also we arranged in a way that she can go at least for a school, at least visiting once in a week. And we given her home exercise program. So we made her understand doing the exercises to make sure she can have good endurance and she can come over her fatigue and she can have good endurance to go to school and do shopping and do some kitchen work. So we arranged also our OTs help to arrange a table and kitchen where she can help her daughters in cooking, which she really likes to do actually. So simple activities like cutting vegetables and like making omelette. So they modify the kitchen for her. And our ustaz, our religious preacher, she given her counseling, telling that nothing harm or nothing wrong in doing the prayer in sitting positions. And he given a lot of religious counseling to her because she's worried that she need to pray by kneeling down, which is not possible and feasible at all. So and after the counseling with Ustaz, she's quite happy and she was started to do more comfortably praying in the sitting position itself. Next slide. Next slide. So summary, 57-year-old lady with breast CA operated and METS2 multi-level spine and right neck of fracture. She had more pain and issues with ADL, psychosocial and spiritual concerns. Treatment adhered to biopsychosocial approach, focused on all aspects of pain, since as we know, pain is multi-dimensional. So not only physical aspects will be affected, but we can see from our patient's concerns, she have a lot of psychosocial issues. So we need to approach a patient with a BPS approach. And during the discharge, she really took treatment for 6 months, weekly once with us. And during the discharge, she has a good score in BPI, 31 out of 70. So, and also in CATS index, from moderately dependent, she became low dependent. Still, of course, she need to use wheelchair, but still she can take few steps only. But she can able to carry out all the tasks, and she visited a school weekly once, and she go for shopping. She can able to plan well, and she can lead a meaningful life with her problem. As we know, we cannot treat this pain completely since it has a bone trauma and fracture which is unhealed, and we can't treat this surgically also. So we need to what we have focused is improving the quality of life of the patient, how to cope up and how to modify the strategies in managing pain, including giving medical support as well as psychosocial support. So it's very essential to treat a patient with pain in multidimensional way rather than treating only physical aspect of the pain. Yeah. Next slide. Yeah. So our discussion points. So how realistic our physiotherapy goal setting can be done during end of life palliative care. As we discussed a lot recently with our doctor's presentation, different modalities, and we talk always about indication or contraindicated, but how we're going to use this in end of life patients, whether we're going to help them in a meaningful life, able to, like example, we took this decision of taking few steps is to make her a bit of independent, though we discouraged her from walking completely with full weight bearing. So this consensus we received through the team of doctors discuss, and they say, and this happened because the patient is in end of life stage and she has certain expectations, and we thought we could able to achieve few things. So but how realistic it should be, that is a one question. And how pain education, exercises and self-management skills can aid confidence in palliative care patients. So we always talk about pain to the patient, but always we say we have a fracture, we should not do certain things, you cannot do certain things, but rather we need to think about what things can patient do with this limitation. So it might be simple things for us, but for patients it's very meaningful, helping the kitchen work or going to school once in a week, so and meeting the relatives. So these all things should set as a physiotherapy goal. That is very important, where we are able to reduce the pain interference in the daily activities. So that is one thing which we need to focus. And how can we improve, as I said, like in all the domains of quality of life with the present condition. And these three questions, which is very useful for us to think, as well as if anything missed here in the management or suggestions to improve the care further. I think we are open to get the suggestions from you and doctor as well. So that ends my presentation for today.
Very good, Murugavel. Very good.
Yeah, thank you, sir.
Right. So here is a patient, 57 years old female with cancer prostate, cancer breast, operated. After 3 years, she developed metastasis in many places. She developed fracture neck of femur on the right side, inoperable. She has 2 daughters. She herself is a teacher working in a school. He was working in a school. So this is the background. Now, how are you going to approach this patient? So in my opinion, 2 things are the pain management and the mobility, ambulation of the patient are 2 eyes for a physiotherapist. Number 1, management of pain, and ambulation of the patient, making the patient to mobile. So are 2 important tasks of physiotherapists. Now we list out the problems of this patient. She is in the terminal stage of cancer prostate, cancer breast with the secondaries, fracture neck of femur. We will list out the problems. You can use the chat box. What are the problems she has? You can talk also. What are the problems? Pain from Manika Saxena. Patient has pain. Okay. What else can be done? Actually, this case was well managed by the team from Murugavel Manivasagam. What else can be done? Because the patient might have received all the palliative care medicine. All the patient was seen by palliative care physician as well. And necessary physiotherapy care was also given. What else can be given for pain? Actually, the initial pain score, according to the brief pain inventory, it was 56 out of 70. From 56 out of 70, it has come down to 31 out of 70. to a greater extent, the pain has been reduced through various measures. Is it possible to give her a pain-free life? This is one. What are the other problems? Number one, pain. Number two,
reduce hip range of motion and hip muscle strength.
motion.
And arm length.
She is
Not audible, sir.
She is not able to walk. Shall we say not able to walk? This muscles are weak around the right hip, restricted range of motion because of the fractured neck. So she is not able to walk. This is the second problem. Anything else?
Can I answer, doctor?
Sorry?
Can I say?
Yes, Tarun.
I think the case clearly depicts that the clear attempt has been made to increase mobility with a lot of caution and all, and there has been some success on that, because that's a very important aspect for this, because she's still middle age, she's not elderly, but there may be two things we can do, especially for the pain perspective. One thing we can do that still there we need to find out whether she is in denial or she has accepted the facts that the prognosis may not be as we all expect as a physician or the caregiver or the patient himself, or here in case is herself. If she has got that associated anxiety and those psychological strain, then she has to do breathing exercises, and her sleep quality also should be observed. Whether you use Pittsburgh scale or subjective measure or objective measure, if we can improve the sleep quality, the pain perception will decrease, and also the pain quality, pain grade will decrease here. Because 50 is still young, so if we can do diaphragmatic breathing exercises and those position release techniques, position release methods, patient pain reduces because autonomic dysfunction will be reduced here. So of course we are working on the parasympathetic and sympathetic supplies. So pain quality pain can be decreased by increasing the sleep quality. That's what I say, doctor. Another aspect, 50-year-old, we need to find out whether she is also looking for other perspective, whether the not only the child. If I'm not wrong, she has got children. Can we know that family attributes? Maybe I missed that part.
She has two children. They are about to be graduated.
So she has got, I think, yeah. So if I connect back, she is also having that. She wished to attend the graduation of the elder one. So that part also has to be subjected to the proper counseling, whether it's possible for her or not. If she is able to attend, there is a chance, fair chance, then she should be motivated that she should keep the goals in the long-term goal or the short-term goals. But if it is not possible, those goals also can be made realistic. That will also take her away from that, like unnecessary she is pushing her. But I have not seen the patient, but as we understand by the respectable presenter, quite well narrated. I think I'll stop here because I'm
Yeah. Thank you, Tarun. Any other answer regarding the pain and how to make her mobile, how to make her ambulant?
Mr. Muruguvel, have you tried the wheelchair so that she's at least movable around her place? She has that.
Yes, we did. She is mobile with the wheelchair. That's why our OT team helps with self-mobility with the wheelchair. But she cannot walk, of course, with her legs with full weight bearing. The thing is, she can able to, but she should not. So that is a thing, right? Because of the active fracture in the neck of femur.
But she's still freely moving around with a wheelchair. At least she has got that freedom.
Yeah, that's what we did. So our aim is to encourage her to go for weekly shopping. She used to. It's more like touching because every time she come to see me every week, she buy a biscuit packet for me. So that's because she started going to shopping to tell me that she's going with the wheelchair. Initially, she nearly for a few years she didn't go anywhere out. because of this. So slowly we educate her and we said what is important for her, and we need to take a decision along with the family members and patient, make her understand that we cannot achieve full weight bearing walking at all, but still it doesn't mean we cannot do certain things in our life. So that understanding happened after thorough education with the patient. And also we expected as I said, limitations. We cannot, we need to set the realistic expectations rather than unrealistic. Yeah.
I think there's one more point I would like to add, like the short-term goals, long-term goals, and what is patient goals. So patient goals are quite well addressed here. So, and also you had a good discussion with the doctor, physicians, and the team whether she should be able to. All the three components has been addressed. Pain, yes.
Anybody would like to add? Murugavel team has done their best. He is looking for some more ways to help the patient. Definitely Tarun contributed. Somebody else want to add? Can you open my PowerPoint? The last 3 slides.
Sure, sir.
Sir, would braces, fracture braces help her?
Sorry?
The femur fracture?
1 minute. Can you open my PowerPoint? Last 3. Yes. So this already we discussed. Okay. Next slide. Next slide. Next. No. Last. Next. No. Next. Next. Down. 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 Next. It has 3 more slides. No. Go to the back. Go to the last 3 slides. Last 3 slides. Yes. Go to 166. Okay. This is called ischial weight relieving orthosis. Suppose the patient is not able to bond the weight at the hip level for some reasons. The weight can be relieved at the level of the ischial tuberosity. So this is a hip knee ankle foot orthosis with a ischial weight bearing. Well, you can think about this. Okay. The only problem is cosmetically whether the patient may like it or not, but this will serve 2 purposes. Number 1, it may reduce the pain. The patient may be able to walk better because weight is relieved at the ischial level itself. No weight will go to any of the major joints like hip, knee, ankle. What about a orthotic setup, Murugavel, in your place?
It's very difficult here, sir. So they make only the basic orthosis.
Okay.
So it's very difficult to, of course, but we can suggest, to make.
You can think about this. Okay, definitely this will help the pain because when the surgery is contraindicated, this is the only way where the weight relief can be achieved. This will help for pain reduction as well for better ambulation. This is the hip knee ankle foot orthosis with ischial weight bearing orthosis. Right. Next one. Next slide. Somebody in the chat box, somebody typed electrical wheelchair. The patient is financially sound. She is still getting her salary from the school. So affordability is not a problem. Already she is using the wheelchair phone. She can use the electric wheelchair to move around in the city itself. Next slide. This is the relaxation therapy, Jacobson hold and relaxation technique. Varun suggested for pain relief. This will also help the patient to relieve the pain and anxiety. Jacobson relaxant. This Murugavel, you yourself can apply this to the patient.
Yes. Yes.
So I have suggested 3 things. Number 1, hip knee angle foot orthosis with ischal weight bearing. Number 2, mechanized electrical wheelchair. Third one, for pain relief and to relieve the anxiety or depression. You yourself can teach the patient Jacobson hold and relax technique. These are the 3 things that came to my mind when I saw your presentation. Still, if anybody would like to contribute, you can contribute. That will help Murugavel to help the patient.
Thank you, sir.
There is one more. We can use it if they can afford. Is bit on the costlier end, but they call like a robotic walking assist device.
Excellent. It's excellent. Nothing very expensive. 20 lakhs.
Yeah, it's very expensive. Yes, it's very expensive.
Patient can afford. Yes, it's a good choice. And I don't think the patient has reached the end of life here. Murugavel, has she?
She is an end of life now. Yeah.
What do you say?
Pardon? No, she because her now recently she have that like now stage 3 when we started to see. So the problem is the deterioration comes on and off. So that is another issue. It's not a progressive patient where we can implement expensive equipments or orthoses. So sometimes she have other ailments, other problems. So which also like delaying the therapy. Sometimes she cannot able to adhere to exercise for some time after long gap. So she will have a break in her physiotherapy. Medically, she have that instability. Yeah.
This is the correct time to teach her the relaxation technique.
Yes.
Please consider this one.
Yes, sir. Thank you.
Right. Any other suggestions? Hari Babu has the chat box type, electrical wheelchair can reduce her exertion. Yes, it's a good answer. And in my opinion, the patient was well managed by Murugavel team. Good, very good. Anything else?
Sir, thank you, sir. Thank you for your valuable inputs and recommendations. Thank you, Murugavel, for the wonderful presentation. And I appreciate all our participants for your participation and your inputs and this one on all. Thank you, everyone. And it's time to wind up our this session, today's session. And now to Mr. Vaishnav. Vaishnav,